All right, good afternoon. So we were interrupted during lecture today, and I wanted to finish out this information in sort of a nice package, and I felt like this might be a great way to do it. So this was the slide that the projector went out on, and I was describing this dermagraft technology, which is a living fibroblast patch. Donor fibroblasts were taken from neonatal foreskin. We cultured these in tissue culture and made basically a tissue engineered skin. And on this slide, what you're seeing is you're actually seeing week 0 or day 0, and then subsequent treatments in the diabetic foot ulcer. So this is the heel of a patient after dermagraft was implanted every week for 8 weeks, and we followed it out to week 10. And you can see by week 10 that this wound is completely closed. And at week 0, this had been open for 6 months. And so this is a common situation that happens with diabetic patients. The issue is a perfusion issue or a vascular issue, and diabetes that's unmanaged can cause vascular abnormalities. And then the blood vessels become compromised. They no longer transport oxygenated blood to the distal extremities. A small cut or wound turns into an infection. And because there's no blood going into the area, it just doesn't heal. And that infection continues to move, and the tissue becomes necrotic and it moves upwards. And so unfortunately, what happens, these patients are at risk of amputation. And so if we look at the next slide, we can see in this study what's called laser Doppler. So this is a way to evaluate perfusion or blood flow into an area. And in panel A, B, and C, we're tracing the wound, and then you can appreciate to the right of that image where we've traced the laser Doppler coloration. The reds and the yellows are higher blood flow, and the blues are lower blood flow. And you can see in the area that was in the wound at week 1, this is week 1, week 3, week 5, that the blood flow is increasing inside the wound bed, where, after 4 or 5 weeks, we start seeing blood flow inside the circumscribed wound bed. And so this is really the mechanism of action. And on this next slide, it's actually highlighted, and it's highlighted in an assay. This is a benchtop assay where we implant this dermagraft onto a chick egg. This is a chick choriontonic membrane assay. And so you open up the egg, you implant the membrane or the tissue engineered skin onto the membrane, and blood vessels start growing in. And you can see in the control, you can just see the mesh. There's no cells, there's no dermagraft, it's just the mesh. Here is the full tissue engineered skin. You can appreciate these vascular elements that are brand new. And this element known as vascular endothelial growth factor, or VEGF, this is sort of the magic growth factor that's manufactured by this tissue engineered skin. And so production after a day, production after 2 days is increased, and we're starting to pump out more angiogenic growth factors to promote vascularization of the wound bed. So I told you in lecture that we've got some warnings, and these warnings are just because these images are pretty graphic. So I just want to let you know the background of this particular patient. It wasn't part of the diabetic foot ulcer study. It was a totally different clinical evaluation. This was an individual that unfortunately had an accident when they were cutting wood with a chainsaw, and it slipped and it actually hit them in the face. And so you ready for it? You can look away if you need to, but this is the wound. This is the wound that actually was created. And if you're able to, kind of analyze this, you can kind of appreciate this is a full thickness wound. I mean, we're down through the epidermis, the dermis. We're seeing subcutaneous fat, especially in the upper lip. And, it transcends from, the patient's upper left above the eye to essentially the patient's right lower lip. And I'm going to show you the image now of post-surgery. So the wounds were approximated. Dermograft is actually laid within the wound bed and on top. And this was closed with suture and then with butterfly adhesive bandages. And then the next image is 1 year later. And this was the challenge that I asked you in lecture. I want you now to kind of analyze, and I want you to tell me if you think that this healing response that we see in the skin in this particular patient is full regeneration and return of function, or is it fibrosis or healing with the fibrosis, or is it somewhere on that spectrum or somewhere in between? So, answer that question. I'm going to ask it to you in class. I'll probably show this image, and I just want to hear what your responses are, because I think it's quite fascinating. The detail that you all will come up with will be interesting to discuss in our next class period. And the last little segment of this lecture is actually going to be on this video. And so I'm going to queue up this video, and then I'll talk with you a little bit about it. Skin is the largest organ in the body. It's severely burned. The standard techniques that we have now, that takes weeks, months, sometimes. And the reason why people die is because of infections that develop while we're waiting for the skin. So if we can find a way to get normal, healthy skin, as much of it as we want, within a week, that's the holy grail of burn surgery. Gerlach thinks he's found a way, but he'll need it.
For the skin cell gun, found a device for the deposition of skin cells onto the wound.
It looked like something you'd see in Star Wars. This is Matt Urim, state police officer from Pennsylvania. He's one of the first people to be treated with the gun. I attended a July 5th party at a friend's house, and there was a small bonfire. I was standing next to the bonfire, and an individual decided to throw a cup of gasoline on the fire. The worst part was my face. It was the whole right side of my face here, my ear, my neck, and my shoulder, and the entire top part of my arm. Urim had suffered severe second-degree burns. This photo shows what a second-degree burn looks like. The arm kind of looked like a piece of charred meat, like a hot dog was left on a grill too long. So I'm just going to pause the video real quick and kind of point out that that image of the second-degree burn is blistering, and we talked about this in lecture, so you can clearly see the blistering, and that's indicative. Like a hot dog was left on a grill too long. Doctor said that I might be a candidate for this new procedure, which is a spray gun, and asked me if I would be interested.
Skin cell spraying is like paint spraying. Just you need a more sophisticated device, like computer controlled. We isolate cells from the healthy part of the skin, the patient's own cells, which can be taken in a water solution, and that solution is prepared for cell spraying.
Basically, what they were doing was taking my stem cells from my skin and putting them all in the gun and spraying it on my arm. Scientists have been able to regenerate sheets of skin for decades. The problem is it takes weeks for that skin to grow, and the new skin is extremely fragile. Gerlach's gun solves both of these problems.
It takes like 1.5 hours to take the biopsy, to isolate the cells, and to spray the cells.
This is what your skin probably looked like before treatment. This is what
it look like 4 days after it was sprinkled with stem cells?
They did it on a Friday, and my follow-up was that Monday, and burn unit said it was killed.
Though the skin gun is still experimental, over a dozen patients have already been successfully treated.
My husband and I have never been more active.
Okay, so skin gun, pretty cool technology, really cutting edge, like what's happening now. That was at the McGowan Institute of Regenerative Medicine, which is in Pittsburgh. And, these types of results are happening in labs kind of all over the country, which is quite fascinating. So I just wanted an opportunity to kind of finish out the lecture today, show you a little bit about the dermograft technology that we were doing. Again, this is in the 90s and the early 2000s, still being sold today. But now we see new developments like the skin gun, ways that we can actually deliver new therapeutics into the clinic. So I think it's just a fun field to be in. And I wanted to make sure that we had a chance to kind of wrap it up today. All right. Thanks for listening in.